Afternoon, folks. So for those of you who are in my anatomy and physiology classes, this is going to be our lesson on the lower respiratory tracts, having previously talked about the upper respiratory tracts in class. If you were not in that class, I'm sorry I don't have a digital lecture for you to fall back on. You might want to do your reading somewhere else. But right now, we're getting into the lower respiratory tract. For anyone who I do have for one of my classes, then I'm going to recommend two things that in preparation for this lecture, you might want to go on Blackboard, get a copy of my notes that I have posted there. I've got a handout there that's lecture notes on this lesson, contains all the relevant vocabulary so that you'll be able to follow along and see what's happening and have all of the spellings of the words and so forth. Also, I strongly recommend if you can have your textbook or your lab manual open to be looking at diagrams while we are discussing all of this. Under this format, I really don't have a good place to sketch, and holding up diagrams in front of the camera is going to be exceedingly weird and awkward and not very helpful. So if you can have a visual in front of you from your text or your lab manual, that would be helpful for what's going to be coming. Also, for those of you who I do have for class right now for this, the assignments and quizzes and so forth going with this lesson are not going to be discussed in this video. I'm going to post them to the Blackboard site. I don't want anybody to have to page through the video and look for the right frames where I was actually talking about the assignment to know that information. So, that said, let's get underway here. Up till this point in time, we've been following the path of air through the upper respiratory tract, entering via the nares or nostrils, passing through the nasal cavity, going through the pharynx, first passing through the nasopharynx, and then through the oropharynx. Now, you might recall at the bottom of the oropharynx, we're going to find that there's a two-way split. There are two passageways that things can go. One of those passageways is going to lead into the laryngopharynx, which heads down to the esophagus. The laryngopharynx is not part of the respiratory tract. It is technically a digestive structure that is taking food down from the rest of the pharynx into the esophagus and eventually from there into the stomach. We are interested in the other branch from there, the one that is going to go in through the opening called the glottis. You might recall the bottom of the oropharynx. We're going to find an opening called the glottis. The glottis is covered over by a flap of tissue called the epiglottis that folds down when you swallow to cover up the glottal opening, so that in that way you don't have food or water going into the glottis and entering the lower respiratory tract. We've all had the uncomfortable experience of food going down the wrong pipe, as we call it, whenever it goes through there because the epiglottis is not fully closed at the time that you swallow, or because it opens partially while you are swallowing because you cough or you're laughing or talking or something while you swallow. So, once you get through the glottis, we are moving into the first portion of the lower respiratory tract, which is called the larynx, L-A-R-Y-N-X, better known as the voice box. Larynx is located in the anterior part of your throat, extends from the base of your tongue. The base of your tongue is not at the back of your mouth. The base of your tongue is down in the oropharynx, and goes from the glottis to the trachea, or the windpipe. Purpose of the larynx, fundamentally, is to pass air from the pharynx to the trachea. Now, the structure of the larynx is largely defined by a total of 9 masses of cartilage joined to each other via muscles and ligaments. Those cartilages frame the larynx and form what we call the quote-unquote voice box. The largest of these is a mass called the thyroid cartilage. The thyroid cartilage forms the bulge in your throat that is sometimes called the Adam's apple. And if you put your fingertips right about here in the center of your throat, you will feel that bulge there. That is the Adam's apple. It is generally larger in males than it is in females, simply because one of the effects of testosterone is it causes enlarging of the cartilage masses associated with it. So a lot of times you have that prominent bulge that sticks out right there in the throats of men, usually less so in women, but there is some variation. We often call that the Adam's apple. You've probably all heard that term before. Comes back to the biblical story of the apple, and the idea, this bit of folklore that they had about it in the Middle Ages was that when Adam bit into the apple that Eve gave him, a piece of the apple stuck in his throat. And that's supposedly why men have a more prominent one than women do. But, that's just your, little bit of folklore trivia there for the day. So we have the thyroid cartilage making up the main mass of the Adam's apple. We have some other cartilage masses surrounding it and framing it. I'm not going to go through all the different ones. It's hard to do without a diagram. Look in your lab manual and you will see a good diagram of the structure of the larynx. So let's talk for a moment about the glottis itself, that opening, because this is important for reasons that have things to do other than just the passage of air. If you were looking at the glottis, lift up the epiglottis. Epiglottis is not folded down to cover it up. Epiglottis, by the way, is a mass of elastic cartilage that projects superiorly towards the tongue. It's the only part of the vocal apparatus that's made of elastic rather than hyaline cartilage. All the cartilage you find in the voice box is hyaline cartilage. Now, on either side of the glottis, you're going to find two pairs of ligaments. You're going to find a pair of ligaments superior and a pair of ligaments inferior. Those ligaments frame the opening to the glottis. They're covered in mucous membranes, and we refer to them as the vocal folds sometimes. The uppermost, the superior pair of ligaments to either side of the glottis is called the vestibular folds. They are also known as the false vocal cords. They are not actually involved in the process of speech, but they are right there above the real vocal cords, so it's easy to mistake them, hence false vocal cords. Beneath them, you will find a pair of inferior ligaments. Those are known as the vocal folds or the true vocal cords. Whenever you are swallowing, not only does the epiglottis fold down, but the vocal folds, the superior and inferior ligaments, are going to pinch together. They're going to close up to shutter that opening through the glottis. Now, the true vocal cords are quite important because they're involved in how we control vocalization. The way this works is that whenever you're talking, your vocal cords are going to vibrate. We can adjust the tension on the vocal cords. When you're learning how to talk when you're little, one of the things you're actually doing is learning how to control your vocal cords. You're learning how to adjust the tension on them. We don't have to consciously think about it. You don't sit here and think, okay, I'm going to pull on that vocal cord right now. But when you talk, that's what's happening. By increasing the tension on the vocal cord, you make higher pitched sounds. Whenever you reduce the tension on the vocal cord, you make lower pitched sounds. At puberty, one of the things that happens to men with the increase in testosterone levels is that the vocal folds get longer and thicker. And one of the effects of that is that it tends to deepen and lower the pitch of the voice. But all of us can adjust the pitch of our voice to a certain extent. If you're a singer, you know that you do different things with your throat to sing higher or to sing lower. And all that really involves is changing the tension on the vocal folds. When you speak, the vocal folds are going to vibrate. You force air up from the lower respiratory tract. The air passes over the vocal folds, and it picks up that vibration, carrying that sound vibration up with the air. Then when that air enters your mouth, your movements of your lips and your tongue and your jaw are going to shape that air and change the way it flows to cause you to make specific sounds. Your nasopharynx and your nasal cavity act as a resonating chamber, providing echo, which gives more resonance, more volume to the voice. You can also adjust your vocal volume by increasing or decreasing the force of air passing over the vocal cords. You all know it takes a lot less breath to whisper than it does to shout. So the vocal folds are vital to this process of speech, which is one of the chief adaptations of Homo sapiens. We are, as I have said more than once in class, a social ape. You're an animal that is adapted to living in groups, and therefore speech is a vital adaptation for our kind. It's a key way that we communicate information, probably the single most effective way that we communicate information with one another. I should point out that we also make adjustments to the glottis for making other noises whenever we are sneezing, whenever we're coughing, whenever we're making other sounds, we have to adjust the glottis and the vocal folds as well. But the most elaborate things that are happening there are the things happening associated with speech. Speech is a vital adaptation for our species for communication. It's also a vital signaling process. Our ability to vocalize is important for sending warning signals, for saying, help, I'm in trouble, or for saying, hey, there comes a predator, or basically alerting others around you, hey, pay attention. And you'll find that even animals that cannot speak can vocalize for that reason. You're going to also find that vocalization is important for speech, for conveying warnings, for sending out reproductive signals, for basically advertising your interest in or availability to a potential reproductive partner. We talked a little bit about that when we talked about pheromone signaling. But we are interested in the sophistication of our speech. Part of that is our vocal apparatus, part of that is our brain. We have regions of the brain dedicated to speech and processing. You talked about that in A&P1. We're not going to go through it right now. But we have a really nifty vocal adaptation to speech as well. Not just the vocal folds, but a bone called the hyoid bone, H-Y-O-I-D, kind of a horseshoe-shaped bone, suspended within the cartilage of the larynx. You might remember the hyoid bone from your Anatomy and Physiology 1 class, looking at the skeleton. It's a pretty fragile bone. It's one of the most easily fractured bones in the body. I used to work in forensic anthropology, and one thing that you learn really quickly in forensics is it's impossible to strangle somebody without breaking their hyoid bone. So one of the things we would look for in a body that we believe might have been strangled is fracturing of the hyoid. It's also one of the bones that's most easily lost whenever a body is decaying or skeletonizing in a natural environment. Again, in a forensic context, if we were out in the woods and we found a skeleton that somebody had buried in a shallow grave somewhere, honestly, it was a rare thing when you found the hyoid bone. As a result, we don't have that many hyoid bones in the archaeological record. So for a long time, we had a question of what was the first animal with a hyoid bone? And that matters because the hyoid bone anchors the vocal folds. And as a result, it's essential to the process of speech. You can't talk the way we talk without a hyoid bone. Other animals that are able to vocalize, like parrots and crows, have a different structure for their voice box. They don't have hyoid bones either. We are the only mammals, living mammals, I should say, that have a hyoid bone. So when did that evolve? For a long time, we weren't sure about that. But then a few years back, we found a skeleton of a Neanderthal. You might recall Neanderthals, they're our cousins, evolutionarily speaking, not our ancestors. And we found a Neanderthal skeleton in, I believe, Croatia that had an intact hyoid bone. That's a very rare find in the archaeological record, so that was pretty special. But that shows us that Neanderthals had the capacity for speech. So given that both Homo sapiens and Neanderthals had it, it is very likely, more likely than not, that the common ancestor of those two groups of humans had a hyoid bone as well. And therefore, we have to push the origins of speech as an adaptation back to at least the last common ancestor of Homo sapiens and Neanderthals, which probably means we're pushing the origins of speech back at least 700 to 900,000 years, if not further back. So speech is something that, in all probability, predated Homo sapiens. We were not the first talking animal. All right, though. So move down through the larynx. At the base of the larynx, you're going to find an opening leading into a long membranous tube called the trachea, T-R-A-C-H-E-A, also called the windpipe. And the trachea is going to be the bridge between the larynx and the bronchi, the airways of the lungs. If you're following the trachea on the rest of the body, trachea originates right around here. It begins at the level of T5, the fifth cervical vertebra, and extends down about 10 to 12 centimeters. centimeters, 10 to 12 centimeters long, so about the length of your hand. Average adult trachea is approximately 12 millimeters wide, a little bit more than a centimeter, or slightly thicker than your thumb. Now, if you're looking at the trachea, it's a membranous tube. It's lined with a pseudostratified ciliated epithelium. Lots of goblet cells, which you might recall from A&P1 in histology. Goblet cells secrete and store mucus in little pockets. The mucus production of the trachea is very, very important for helping to trap particles that you've inhaled that far. The cilia lining the trachea continually push that mucus coat up, out through the larynx and into your throat where you swallow it to clean out those particles. Pardon me, a little bit of tracheal irritation there. Speaking of, if your trachea gets irritated, you're going to get a cough response. The trachea is powerfully impelled to cough whenever foreign bodies or particles enter it, because the trachea, after all, is one of the last points before things get down into the lungs. So whenever anything penetrates the trachea that's not supposed to be there, it triggers a cough reflex in order to try to push that particle, that foreign obstruction, whatever it is, up and out of the trachea so it doesn't get down into your lungs. There are actually muscles, smooth muscles at the rear of the trachea. The smooth muscle at the posterior of the trachea is called the trachealis, and it reflexively contracts in response to the cough reflex. At that time, the muscles of the diaphragm and the lungs also work to force air upward, so that you've, well, not the lungs don't have muscles. I should say the muscles of the diaphragm and the rib cage act to force air upward to expel whatever was irritating the trachea. Of course, when you're sick, that tracheal irritation may not be because of an actual blockage. It might be because of inflammation. You might have tracheitis, inflammation of the trachea, in which case there's continual irritation, which causes a persistent cough. Now, in order to keep the trachea open, to keep it from collapsing, you've got little ring-shaped bands of cartilage along its length. Every couple of millimeters, you're going to find a grand total of about 15 to 20 of these C-shaped bands of hyaline cartilage along the length of the trachea, keeping it open so it doesn't collapse. I say they are C-shaped because they're not complete rings. They are open at the bottom, or rather I should say they're open at the posterior. Swallow. Watch your throat. You swallow, your throat bulges forward, right? The reason for that is because your esophagus runs behind your trachea, and therefore whenever you swallow, the esophagus bulges forward as you take in a mass of food or a mass of water or what have you. Now, in order for the esophagus to bulge forward, it's got to have something to bulge into. If the trachea were closed with solid rings all the way around, it wouldn't have that kind of flexibility. But because it's a C-shaped ring that's open at the posterior, that means the esophagus can bulge forward into the trachea when you swallow. So just watch, if you will, if you can see my throat going on here. Don't know how clear that was, but you can hopefully see the bulging forward. And that was the trachea and the larynx being pushed forward by the stretching of the laryngopharynx and the esophagus as the water passed through. Incidentally, fun little fact about the trachea. The trachea is right now the only organ in the body that we have successfully 3D printed copies of. There are people who have had their tracheas damaged or destroyed that are now walking around in the world right now with 3D printed tracheas that were produced to replace the natural tube that they were supposed to have. Now, at the bottom of the trachea, you're going to find a final ridge of cartilage called the carina. And the carina marks the splitting points where the trachea branches into the airways known as the bronchi. One of them is a bronchus, plural is bronchi. The bronchi are the air passages of the lungs. Now, The trachea itself is not in the lung. The trachea ends outside of and slightly between the lungs at the carina, and then the bronchi branch down from that and enter the lungs. Now, once the bronchi get into the lungs, an important thing to think about this, and we're going to talk about the lungs a little bit more in just a moment, is that your lungs do not just consist of empty bags. We think of the lung and we think, okay, it's just a bag that inflates and deflates, inflates and deflates. It's not. If you look inside the lung, if you were to do a cross section of a lung and cut down through it, what you would see was an extensive branching collection of tubes. That most of the interior of the lungs is taken up by branching, splitting bronchi. You start off with a couple of big bronchi, they split into smaller ones, which split into smaller ones, which split into smaller ones. So don't think of the lung as basically just a cone-shaped bag in your chest. It's actually full of lots and lots of individually smaller branched passageways. Talk more about those bronchi in just a moment. But the key feature of the bronchi is that they are serving to increase the overall surface area inside the lungs. If the lung was just a bag, then it would just have an internal volume, a certain surface area on the inside based on the size of that sac. But because it has all these many little branching passages within it, and each of them has their own little interior surface, that means that having lots of little internal branching passages gives the lungs a much larger internal surface area than they would have if the lung was just an undifferentiated sac. To give you an idea about this, the total internal surface area of the lungs, if I were to take all the membranes inside of my lungs, all the respiratory membranes, spread them out flat, I would die. All right, so yeah, in practical terms, to give you a sense of what I'm talking about here, the total surface area of all the internal respiratory membranes in your lungs, if you spread them out flat, it's about the size of a tennis court. And that's good because that provides us lots of surface area for the uptake of oxygen. But before we get into how that works, let's follow these bronchi. You go from the carina and you split down into a left bronchus and a right bronchus, which are heading down to the left and right lungs, respectively. The bronchi, like the trachea, are highly sensitive to foreign material going into them. If anything does get down this far that's not supposed to be there, it triggers a very powerful cough reflex in order to try to expel it. Pardon me, folks, having some asthma trouble today, appropriately enough, while I am talking about the lungs. And the more you talk about it, you all know how that goes. You think about coughing, talk about coughing, you feel the cough reflex building up, right? Now, when the bronchi are extending down, interesting thing about this, the left bronchus is a little bit different in its angle than the right bronchus. You're going to find that the left bronchus is a bit more horizontal in its orientation. The right bronchus is a little bit more vertical. The reason for that is because you might recall your heart is tilted to the left side of the chest, and therefore the left bronchus is tilted at a different angle to make room for the heart. One of the features of this, by the way, is that foreign materials that happen to get down this far are more likely to go down the right bronchus than they are to go down the left bronchus, because the more horizontal orientation of the left bronchus means there's not as much of a vertical passageway, whereas the right bronchus just kind of angles downward. So anything that does get aspirated, anything that does get breathed that far down into your lungs is way more likely to enter the right lung than it is the left. All right, so that said, we go down through these bronchi, and the bronchi lead into the lungs. The lungs, of course, are the principal organs of respiration. They're where we've been going this whole time. They mark the end points of the respiratory tract. We started at the nasal passageways. We went down through the nares, nasal cavity, nasopharynx, oropharynx, larynx, trachea, bronchi. And those bronchi are going to then branch down into the lungs. Now, your lungs are paired organs. Almost all vertebrates have paired lungs. There are a couple of exceptions. Some salamanders, some lizards, and snakes only have one lung, but you, as a human being, like all mammals, have two. Your lungs are roughly cone-shaped organs. The base of the lung, can't see it here, base of the lung rests right about here on top of your diaphragm, the sheet of muscle between the abdomen and the thoracic cavity. Apex of the lung, the point at the top of the lung, comes to right around here. Inflate your lungs, you can feel it fills up right to about here. Your lungs actually come up to approximately 2.5 centimeters above your clavicles, so about an inch above your collarbone. And again, do that yourself. Inhale. Feel the lung fills up to right about this spot right here. Lungs are entirely contained within the thoracic cavity, the upper cavity of the body, the main cavity of the body. You might recall from A&P1 talking about your body cavity that within the thoracic cavity, we have two smaller cavities called the pleural cavities, P-L-E-U-R-A-L, the pleural cavities, one pleural cavity for each lung. You're going to find that within the pleural cavities, the lungs are surrounded by moist membranes called the pleurae, P-L-E-U-R-A-E, the pleurae. If you're talking about just one of them, it is a pleura. And the pleura are the membranes that are going to cover the lungs and form the lining of those cavities. The pleural membranes have two parts. You have the parietal pleura. The parietal pleura covers the inner thoracic wall. So the parietal pleura forms the inner thoracic wall, not only of the parietal cavities, of the pleural cavities, but also forms the wall of the mediastinum, the cavity that contains the heart itself. The parietal pleura also covers the superior surface of the diaphragm, that sheet of muscle we talked about here. We also have the visceral pleura. The visceral pleura is going to be the portion of that membrane that covers the surface of the lung itself. Remember, the word visceral means having to do with organs. The space between the two contains a liquid, a serous rather than mucus fluid, called pleural fluid. The pleural fluid serves to lubricate the pleura so that there's not friction whenever you're breathing in and out. Eases the movement of the lungs as they change shape during respiration. Sorry, itchy eyes, bad allergies right now. But the pleural membranes, incidentally, can become inflamed. Sometimes this is a complication of severe chest infections, and it's sometimes, more often, a complication of surgery. That if you had an open thoracic surgery, if we've opened up your thoracic cavity for any reason, sometimes the pleural membranes will become inflamed. We call that pleuritis, inflammation of the pleural membranes. It's quite painful, causes every breath to become painful, and if untreated, especially if it's due to infection, it can be lethal fairly quickly. People do die of pleuritis. Now, if we are looking at your two lungs, the right lung is larger than the left lung. The left lung has to be a bit smaller to make space for the heart, which again, remember, is tilted off to the left side. If we look at the right lung, it is divided into three sections that we call the lobes of the lung. We have a superior lobe, a middle lobe, and an inferior lobe. Remember when we inflated lungs in lab, that they didn't inflate all at once, right? You know, that a portion would inflate, then another portion, then another portion. You're seeing each of those lobes inflate independently. The left lung only has two lobes, a superior lobe and an inferior lobe. Doesn't have a middle lobe. You'll find that in the right lung, incidentally, that the orientation of the lobes is that you've got the middle lobe kind of tucked behind the superior and inferior lobes. There are deep fissures between the lobes. If you're looking at a lung, you can clearly see where the lobes are distinct from one another on the outside. They're internally connected, externally divided up. Now, if you look at each lobe internally, each lobe is divided up internally into smaller compartments called bronchopulmonary segments. Broncho, B-R-O-N-C-H-O. That means pertaining to the bronchi. Pulmonary, P-U-L-M-O-N-A-R-Y. So bronchopulmonary. That is pertaining to the bronchi and the lungs. So yeah, each lung is divided into bronchopulmonary segments internally. Each lobe has a number of bronchopulmonary segments. So you've got 3 lobes in the right lung. Each lobe of the right lung has 10 bronchopulmonary segments. You have 2 lobes in the left lung. Each lobe of the left lung has 9 bronchopulmonary segments. Therefore, you have a total of 5 lobes to your lungs. You have a grand total of 48 bronchopulmonary segments. 30 in the right lung, 10 per lobe. 18 in the left lung, 9 per lobe. The segments, incidentally, are distinct compartments from one another. They can be independently surgically removed if they are damaged or diseased. So if something goes wrong with one, it's damaged by emphysema or lung cancer or something like that, we can take out that individual segment and leave the rest of the lobe there to do its job. You can also remove entire lobes from the lung if you need to and leave the remaining lobes there to continue doing their job. Now, you have the 2 main bronchi that come down into the lungs from the trachea. We call those the primary or main bronchi. You've got a left bronchus and a right bronchus. Once they get down into the lungs, they're going to branch extensively to form what we sometimes call the bronchopulmonary tree, because if you're looking at it, it kind of looks like an upside down tree with no leaves on the branches, just branching and branching and branching out. Each primary bronchus, once it gets down into its lung, is going to split into smaller branches called lobar or secondary bronchi. As the name suggests, you get 1 lobar bronchus per lobe. So there are 3 lobar bronchi in the right lung, 2 lobar bronchi in the left lung. Once they get into the lobes, they're going to split further into tertiary, the word tertiary, T-E-R-T-I-A-R-Y. Yeah, just got lost in the word there for a second. The word tertiary means third. The tertiary bronchi are called the segmental bronchi because they go to each of the individual segments. So you have 10 segmental bronchi in each lobe of the right lung and 9 segmental bronchi in each lobe of the left lung. But they don't stop branching just when they get down into the segments. They continue branching, smaller and smaller and smaller and smaller. Approximately 16 generations of branching. So once they get down in each segment, they're going to branch and branch and branch again about 16 times. Then we will get down to even smaller branches. About 7 more generations of what we call bronchioles, B-R-O-N-C-H-I-O-L-E-S, bronchioles. And the bronchioles are the tiny little airways, microscopic at this point, that continue into the deeper parts of your lungs. The bronchioles will end with a passageway called terminal bronchioles. Each terminal bronchiole is then going to divide even further into respiratory bronchioles. And you're going to have an average of 7 more generations of those. Some people's lungs have a little bit less branching than others, varies with body size. But those 7 branches of bronchioles, by this time we're super microscopic. We're very, very tiny. At the end of the last respiratory bronchioles, once they branched and branched 7 times, at the ends of those, you're going to find the alveolar ducts, A-L-V-E-O-L-A-R, alveolar. An alveolus is a cavity or opening. So the alveolar ducts extend from the respiratory bronchioles, and they lead into the alveoli. The alveoli are the end of the line. They're the end of the respiratory tract. They are the air sacs of the lungs. A-L-V-E-O-L-I. If you're talking about just one of them, it is an alveolus, A-L-V-E-O-L-U-S. But I can't think of any good reason you talk about just one of them individually, because you have, on average, 300 million of them between your two lungs. 300 million. So with all those generations of branching and branching and branching, we have the primary bronchi that come in. We have a total of 5 secondary or lobar bronchi, 3 in the right lung, 2 in the left. We then have a total of 48 tertiary or segmental bronchi, 30 in the right lung, 18 in the left. We branch down for 16 more generations of branching to the bronchioles. We pass through respiratory bronchioles terminal bronchioles into respiratory bronchioles. We have 7 generations of respiratory bronchioles. We go from there into alveolar ducts, and then at last we terminate in these tiny microscopic air sacs called the alveoli. The alveoli are going to be where gas exchange actually happens. This is where the lungs actually do their action. All this branching up to this point was for the purpose of distributing the air to as many little alveoli as possible. That tennis court surface area I was telling you about, that's the surface area of all those 300 million alveoli put together. And that's the surface area we have for actual gas exchange. So, if I'm looking at the alveoli, if I look at the walls of the alveoli, they are very thin walls, extremely thin. 90% of the cells in the alveolar walls are called type 1 pneumocytes, P-N-E-U-M-O-C-Y-T-E. A pneumocyte is a lung cell. So about 90% of their cells are type 1 pneumocytes. Type 1 pneumocytes form a very thin, simple squamous epithelium. Remember, simple epithelium, one layer, squamous, very flat cells. Simple squamous epithelia are the thinnest membranes in the body. And that has to be that way because that's where most of the gas exchange is going to happen. That is where oxygen diffuses in and carbon dioxide diffuses out across that membrane formed by the type 1 pneumocytes. Now, about 10% of the cells that make up the alveolar sacs are not type 1 pneumocytes, they are type 2 pneumocytes. Those cells are going to be rounded or cuboidal epithelium rather than squamous epithelium, and they are going to secrete a lubricating fluid, a serous fluid called surfactant, S-U-R-F-A-C-T-A-N-T. The surfactant keeps the alveoli moist so that they can freely dissolve gases. It also lubricates them to ease their expansion so that they can freely and smoothly expand and contract. Without surfactant, they would dry out and crack very, very rapidly. Needless to say, the lungs contain a lot of elastic tissue in their walls. Elastic connective tissue is a vital part of the lung because it has to be able to expand and then spring back to its previous shape. Collectively, we refer to all these cells lining the alveoli as the respiratory membrane. Those respiratory membranes are where all of our gas exchange is going to take place. And in their wall, if you look a little bit further back from the membrane, you're going to find the pulmonary capillaries, rich capillary beds in the lungs. The densest capillary beds found in our bodies are found in the tissue of our lungs surrounding the alveoli. Because in that way, those capillaries with their very thin walls can diffuse oxygen in from the lung and release carbon dioxide into the alveoli to be exhaled. Deoxygenated blood, as you all know by now, is delivered to the lungs from the pulmonary circuit. Pardon me. Sorry. So deoxygenated blood is coming into the lungs from the pulmonary circuit, right side of the heart, flows through the pulmonary arteries, goes into smaller and smaller branches till you finally get into these pulmonary capillary beds around the alveoli. Within those pulmonary capillary beds, oxygen is going to diffuse from the lumen of the lung across the respiratory membrane into the bloodstream. there's a higher concentration of oxygen in the air within the lung than there is in the blood at that point. And therefore, diffusion, if you remember diffusion from your chemistry or your Bio 1 classes, always goes from high concentration to low concentration. Therefore, oxygen will diffuse out of the lung into the bloodstream across the alveolar membrane. Carbon dioxide is going to go the opposite way. This deoxygenated blood has a higher concentration of carbon dioxide than the air coming into your lungs does. Therefore, carbon dioxide is going to diffuse out of the bloodstream across the alveolar membrane, the respiratory membrane, into the lumen of the lung so that carbon dioxide can be exhaled whenever you breathe out. Term you will sometimes hear for this in and out process, by the way. Breathing in is inspiration. Breathing out is expiration. So we tend to prefer those terms medically to inhale and exhale. Now, much like the heart needs its own blood supply, you remember they have the coronary circulation that branches off from the aorta to give blood to the muscle of the heart, we also need a blood supply for the lungs themselves, so that they too are getting their own oxygenated supply. So some of the blood from those pulmonary capillaries is going to be diverted into what we call the bronchial circulation. That is the blood supply to the lungs themselves, not to get oxygenated for the rest of the body, but to keep the tissue of the lungs getting the things that they need. So you're going to find a little bit of that freshly oxygenated blood that we just added oxygen to is going to be diverted into bronchial circulation. You will have bronchial arteries that spread oxygenated blood throughout the tissue of the lungs. You will have bronchial veins that drain that blood from the lungs. The bronchial veins converge on larger and larger vessels until they empty into the common pulmonary veins to be delivered back to the heart. All right, so that's our basic lung structure. That's our basic blood flow, that you are going to draw air in, flow through all these passageways that we've been talking about, go in through the nares, nasal cavity, nasopharynx, oropharynx, larynx, trachea, all the generations of bronchi, finally passing through bronchioles, alveolar ducts, and at last finishing in the alveoli. And in the alveoli, we're going to have that two-way gas exchange where oxygen crosses the respiratory membrane into the bloodstream through those pulmonary capillary beds, and carbon dioxide diffuses out of the pulmonary capillary beds into the lung. This is a good time as any to mention, by the way, folks, a detail about our planet's atmosphere that you may or may not already be aware of. Earth's atmosphere is on average about 20% oxygen. So when you take a breath, when you breathe air in, about 20% of what you're taking in is oxygen. About 79% is nitrogen. And about 1% is all the other gases, including carbon dioxide. So when you breathe in, most of what goes into your lungs is not oxygen. Most of it is going to be nitrogen. When you breathe out, most of what goes out of your lungs is also nitrogen. There's only a tiny amount of carbon dioxide relative to the total volume of nitrogen. So mostly when you pump air in and out, you're moving nitrogen in, nitrogen out. You're bringing oxygen in along with that breath. You're sending carbon dioxide out along with it. But don't think, okay, I'm just exhaling a bunch of carbon dioxide, because you're exhaling mostly nitrogen with some carbon dioxide and actually with some oxygen too. Because in the time that it takes for the average breath to go in and out, you don't have enough time to absorb every bit of oxygen that is in that breath. Therefore, some of the oxygen you just pumped in is going to go out as well. All right, so that's the basic lung structure. That's your basic lung anatomy. Let's talk now for a minute about some lung physiology. Let's start talking about how we do all of this. And we have to begin with the most basic component of the process, the thing we call ventilation. 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 Or in other words, what you know more commonly as breathing. Now, I've already established ventilation has 2 cycles: inspiration, that is inhaling, taking air in, and expiration, or exhaling, pushing air back out. Now, the lungs themselves, you might have noticed in my discussion of them, I never talked about muscular tissue because the lungs lack muscles of their own. The lungs cannot inflate and deflate under their own power. All of the action of ventilation is being carried out by muscles surrounding the lungs, specifically muscles associated with the rib cage and muscles associated with the diaphragm. The muscles of inspiration, the muscles involved in inhaling, the things you already know. You've got the diaphragm, which is that sheet of muscle we talked about here. And then think back to your muscles from A and P1. We also have the external intercostals, the superior muscles, superficial muscles between the ribs. We have the scalenes, and we have the pectoralis minor muscles, pecs, Those are all muscles of inspiration. During the course of inspiration, those muscles act to elevate the rib cage and the sternum and to lower the diaphragm. The muscles of expiration are going to consist primarily of abdominal muscles and the internal intercostals, the deep muscles between the ribs. Those muscles serve to depress the rib cage and sternum, lower them as the diaphragm rises. During inspiration, what's going to happen is that your thoracic volume will increase. As the diaphragm moves down and the rib cage elevates, the lungs are going to be stretched along with them. Those pleural membranes bind the lungs to the inside of the thoracic cavity. So as we elevate the rib cage and lower the diaphragm, then the lungs are going to be stretched out. They're going to be expanded. That causes a change in the pleural pressure. The pleural pressure is going to go up as we put more pressure on the inside of the pleural cavities. But as we expand the lungs, the alveoli, those air sacs, are going to get stretched out. And if you stretch out any kind of space, the pressure inside of it is going to drop, which means that alveolar pressure is going to go down as the lungs expand. And as the pressure inside the lungs drops, whenever you have pressure drop in any container, that creates a pressure gradient with what's going on outside of it. It creates suction, in other words. So as my lungs expand, the alveolar pressure in them drops, and that creates suction that pulls air down into that larger space. And that is going to be what happens when you inhale. Enlarge the lungs. As they get bigger, the alveoli expand, internal pressure drops, air rushes in. Now, as the respiratory muscles relax during expiration, pleural pressure is going to drop. There's less pressure on the inside walls of the pleural cavities. But as the lungs shrink, as the rib cage depresses, and as the diaphragm rises, that squeezes the alveoli. That puts more pressure on the alveoli as they shrink. It's like, squeezing a balloon and the air flows out of it faster. It's pretty much exactly what's happening, because as the pleural pressure drops, the alveolar pressure rises. As the alveoli constrict again, once the rib cage and the diaphragm close in around them, they get smaller, their pressure rises, and air is forced back up and out. The lungs easily shrink back down to their previous shape because of elastic recoil. We sometimes just call that lung recoil. All the elastic tissue in the walls aids in them expanding and then contracting back to their previous configuration. Now, when you're engaged in labored breathing, when you're breathing hard, you're exercising or whatever, what you're going to have is more forceful contraction of those muscles. And as those muscles contract more forcefully, that's going to cause greater expansion of the thoracic cavity, and that's going to cause more forceful expelling of air. You're going to, in other words, ventilate more thoroughly. You're going to pull more air in faster. You're going to push more air out more forcefully. You're going to create greater airflow within the lungs. This is all, of course, aided by the surfactant that I mentioned, that lubricating fluid. The surfactants lowers the surface tension of the alveoli, makes it easier for them to expand, and very importantly, prevents them from collapsing during all of this. Now, to make this work, the lungs have to be able to expand well, right? If they can't expand efficiently, you're going to have a problem. The ease with which your lungs expand is called their compliance. C-O-M-P-L-I-A-N-C-E, compliance. So the compliance is the ease with which our lungs and our chest cavities expand. We can measure compliance numerically in liters of air per centimeter of water. And the reason we call it that is because when we're measuring compliance, we have the patient breathe into a tube, and it causes water to rise up within that tube. So our standard measurement is how many liters of air are you exhaling per centimeter that the water goes up in the tube for measuring it. Normal, healthy adult compliance is about 0.13 liters of air per centimeter of water. That's about a healthy value. A little bit higher for men than for women. Male lungs on average are a bit larger. The male thoracic cavity on average is a bit bigger. Greater compliance means you can expand your lungs more easily. Lower compliance means it's more constricted. Why would your compliance go down? Pulmonary fibrosis, scarification of the lungs due to things like black lung disease or other long-term pollutant effects. A collapsed lung due to injury will lower compliance. If you are suffering from bronchitis, if you have inflammation of the bronchi, all of us have experienced bronchitis at some point, then the bronchi are inflamed, they're swollen, they lose compliance, they can't expand as much. If you are suffering from asthma, like I'm having some asthma trouble today, it's why I'm coughing here, part of what's going on there is my bronchi are more constricted. The big thing that happens in asthma is bronchospasms, that is constriction of the bronchi. And when the bronchoconstriction is happening, I lose compliance. I can't fill my lungs as much. I have to fight for air more. If you're suffering from lung cancer, you're going to lose compliance. If you are suffering from pulmonary edema, the fluid pressure from edema building up in the pulmonary circuits, that means it's harder to expand your lungs and you lose compliance. All of these things you can see are things that limit your airflow. Increased compliance, honestly, if you're in good health, the compliance of your lungs is not going to change a whole lot. A well-conditioned athlete can increase the force with which they inhale and exhale. They can increase their compliance a bit. But it's also possible to have a pathological increase in compliance. When you have emphysema, E-M-P-H-E-Y-S-A, emphysema is a lung disease that we're going to talk about a little bit further along. Wait, I spelled that wrong. E-M-P-H-Y-S-E-M-A. There we go. That's correct. Sorry. When you're doing it out loud and not writing it down, brain gets lost there. But one of the long-term effects of emphysema is actually an increase in compliance, because as the lung tissue begins to die in emphysema, honestly, it loses stretchiness. It becomes more plastic. It stretches out. But the problem is it doesn't go back down to its resting shape as easily as it did. So that loss of compliance with that emphysema as the lungs gradually begin to break down is actually not a good thing. In the short term, it helps an emphysemic to get better airflow when their lungs are dying. In the long term, it's a problem. All right, so having established all that, let's talk for a few minutes about lung volume. How do we measure the volume of our lungs? And the lab activity we did not get to do. We can measure a lot of this airflow kind of stuff with a tool called a spirometer, which you breathe out into, and it gives us an idea how much air is moving through your lungs at a given time. We will often do a test called an FEV1 test, forced expiratory vital capacity, which allows us to get an idea of how much air you can take in and breathe out. And that's a very important clinical measure of lung size. Now I'm about to tell you some numbers about how much air moves in and out of the lungs. I want to let you know these are kind of the quote-unquote default numbers for humans. This is the species average. It's going to vary a lot from one individual to another based on age. Obviously, you're going to get bigger as you get older, at least till you hit adulthood. And as you get into old age, your lungs are going to not be as efficient. It's going to vary depending on body size. Obviously, if I have bigger lungs, they're going to have a greater volume than people with smaller lungs. It's going to depend on sex. Men have higher lung volume on average than women do. It's going to depend on your physical conditioning. People who are in good physical condition are going to move air more efficiently through their lungs than people who are more deconditioned. So those are all things that can affect your lung volume. Pathology can as well. Pulmonary diseases like pulmonary edema can reduce the amount that you inflate and deflate your lungs. Lung tumors can take up space and volume. Fibrosis, scarification of the lungs, again due to black lung disease or pollutants or cigarette smoking long term. And spinal deformities, which can bend the body. A lot of people, when they have kyphosis when they get older and the back gets more bent, one of the problems that causes, and one reason why older people are more prone to pneumonia, is because they're not moving air as efficiently in and out of the lungs. The curvature of the spine is putting more pressure on the lung and reducing the volume of air that can be moved in and out. So I'm going to give you some numbers on volumes of air. These are background default baseline values. Individual humans are going to have greater or lesser values for some of these things. So keep that in mind as we go, and also in clinical situations, but these numbers are going to be your starting. All right, so I paused for a minute to write down a few equations that I think would be helpful for you all to see here as we talk about lung volumes. So first off, the most basic measurement of the amount of air going in and out of your lungs is what we call the tidal volume. T-I-D-A-L. The tidal volume is the amount of air that you're pulling in and out of your lungs in a normal breath. For the average healthy adult, the tidal volume is approximately 500 milliliters, or half a liter. In other words, every time I breathe in, I'm breathing in about a half liter of air. I'm breathing out about that same amount. Now that's a normal breath. Obviously, there are times you breathe in more than that. That's why we also have what we call an inspiratory reserve volume. I-N-S-P-I-R-A-T-O-R-Y. Inspiratory reserve volume. That is the volume of air that can be forcefully inhaled beyond the tidal volume. In other words, how much more can you breathe in beyond just a normal breath? So taking a deep breath, how deep can you breathe? For the average healthy adults, the inspiratory reserve volume is about 3,000 milliliters, or about 3 liters of air. To put it another way, we can take in about 6 times more air in a forced breath than we can in a normal breath. Add those two together. Tidal volume, 1 normal breath, plus inspiratory reserve volume, the amount of additional air you can breathe in, and you end up with your inspiratory capacity. That is the maximum amount of air you can take into your lungs, which for a healthy adult human is about 3,500 milliliters, or about 3.5 liters of air. Now let's go the other way. When you exhale, you're breathing out the tidal volume as well. You can breathe out about 500 milliliters of air in a normal breath. But you can keep forcing it out beyond that. Try it yourself. You can breathe out, but you can... Probably couldn't hear me just there, but you can keep on forcing more air out of your lungs. You can push more out than what is going out in a normal breath for the simple reason that you're not breathing out every bit of air in your lungs when you exhale. So the amount of additional air that you can force out of your lungs beyond the tidal volume is called the expiratory reserve volume. E-X-P-I-R-A-T-O-R-Y, the expiratory reserve volume. And for the average healthy adult, expiratory reserve volume is about 1,100 milliliters. So you can push about twice as much air out, forced exhalation, beyond the basic breath in, breath out. Even when you do that, even when you force out as much air as you can, you will never completely empty your lungs. The only time your lungs completely empty is if they are collapsed, and that's a bad situation. Usually happens because of thoracic injury of some kind. But assuming your lung isn't collapsed, it's going to retain some air, even after you've breathed out as much as you possibly can. The amount of air that remains in your lungs at all times is called the residual volume. R-E-S-I-D-U-A-L. The residual volume. That's the dead air, you might say. Usually it's pretty well depleted of oxygen by that point, but it's just kind of in there. And your residual volume is about, for the average healthy adult, about 1,200 milliliters. So if I take the expiratory reserve volume, the amount of air that I can force out beyond a normal breath, add that to the residual volume, the remaining air that will be there even after doing that, I have my functional residual capacity. And if you add those two numbers up, that means my functional residual capacity is about 2,300 milliliters. In other words, after the tidal volume, after a normal breath in, breath out, I've got about 2,300 milliliters of air just still sitting in my lungs. About 2.3 liters are just going to be there unless I am more forcefully inhaling or exhaling. Now, if I add together my inspiratory capacity, the maximum amount of air I can breathe in, plus my functional residual capacity, the maximum amount of air that stays in my lungs under normal circumstances, together that gives me my total lung capacity. In other words, what's the maximum amount of air I can have in my lungs at once? And for the average healthy adult, we have an inspiratory capacity of 3,500 milliliters. We have a functional residual capacity of about 2,300 milliliters, which means that on average, a normal adult has a total lung capacity of about 5,800 milliliters, or about 5.8 liters of air at a time. Let me show you the numbers on that. Got some equations for you here. You can see the top formula there is showing us how much air we can take in. Tidal volume, 500 milliliters, plus inspiratory reserve volume, the amount I can forcefully breathe in beyond that, of 3,000 milliliters, gives me an inspiratory capacity of 3,500 milliliters, the maximum air that I can breathe in. Down below, we're dealing with the amount of air that stays in the lungs. We have the expiratory reserve volume, that's the amount of air I can force out beyond a normal breath, of about 1,100 milliliters. And we have the residual volume, the amount of air that's going to stay in there no matter what, of about 1,200 milliliters. Add those together, and I've got the functional residual capacity, in other words, the normal air that's just kind of hanging out in the lungs after a normal breath, of about 2,300 milliliters. So if I add up the amount of air that's always in the lungs, about 2,300 milliliters, the functional residual capacity, to my inspiratory capacity, the amount of air that I can pull in at once, that's 2,300 milliliters of inspiratory reserve, plus 3,500 milliliters of expiratory reserve, and that gives me my total lung capacity of about 5,800 milliliters. One last volume number here that's important, and one's going to come up more often in a healthcare context, and that is a thing that we call your vital capacity. Your vital capacity is the maximum exhalation after the maximum inhalation. In other words, I breathe in as much as I can, and then I force out as much as I can. If I want to find out my vital capacity, that is the bottom equation you can see here. My vital capacity is calculated as inspiratory capacity, that is how much I can breathe in, plus expiratory reserve volume, the maximum amount I can breathe out. And together, that gives me the average vital capacity for a normal healthy adult of about 4,600 milliliters. In other words, if I breathed in as much as I can and breathed out as much as I can, about 4,600 milliliters of air will move in and out of my lungs. Vital capacity is an important measure of lung health. And you're finding that, like, this is one of the things you're going to test in respiratory function. Any of you who go into respiratory therapy or similar areas, this is a test you're going to do. The forced expiratory vital capacity, FEV1 test, is a really important one. If any of you are asthmatics, you've definitely taken one of these. You all know how that goes. You breathe as hard as you can into a little tube after breathing in as hard as you can, and you keep breathing out till you can't force any more air out of your lungs. So that's a thing that is a test you might end up actually doing on a patient at some point or having to take yourself at some point. Now, as I said before, all these numbers are affected by a lot of factors. They're affected by age. The older you get, the lower these values tend to go. Your sex, on average, males and females. Males will have a little bit bigger lung capacities. Body size. You're a bigger person, you're going to have bigger lungs. Your level of physical conditioning. You exercise more, you're going to improve on this. You will find that the sex difference is that on average, a healthy adult male and a healthy adult female of about the same height, the female's body will have about 20 to 25% lower values for these numbers than the average male. Now, a bunch of things, as I said, can affect this. You know, we can have this changed by spinal deformities, by scarification of the lungs, by tumors, by short-term measures like bronchitis or an asthma attack. These numbers have given you the baseline. One last number I want to give you here is a thing you'll hear about also a lot in clinical contexts, and that is a thing called your minute ventilation. The minute ventilation is the total air moving through the respiratory system per minute. Now, you've already heard normal at rest values, and we're talking about minute ventilation. This is typically at rest unless otherwise stated. All these numbers I gave you are at rest unless otherwise stated. You exercise, these things are going to go up. Now, minute ventilation assumes a tidal volume of about 500 milliliters. You're taking in about half a liter of air every time you breathe in, you breathe out. Average healthy adult is taking about 12 complete breaths per minute. About 2 seconds to inhale, about 3 seconds to exhale. That's 5 seconds for a complete cycle, 12 times in a 60-second minute. So we measure our minute ventilation in liters per minute. I'll spare you the math. Take a tidal volume of 500 milliliters, multiply that by 12 breaths per minute, and you've got a minute ventilation of 6,000 milliliters per minute, or about 6 liters per minute. So sitting here at rest in your chair, you're moving about 6 liters of air in and out of your lungs per minute. All right? Is that making some kind of sense? Now, important thing to keep in mind about all this, folks, is that dead air that's sitting in your lungs, that residual volume, that is air that, for the most part, has been depleted of oxygen already. The more of that you move out at a time, the more fresh air you're bringing in, and therefore, the more effectively your body is collecting oxygen. More about that in a minute, but I want you to keep that in mind. So, that's how we get the air in and out. Let's talk about the actual action of gas exchange. What happens to that air once it's in there? Ventilation supplies air to the alveoli. And as I said a few minutes ago, the alveoli is where gas exchange actually happens. That is, oxygen diffuses into the bloodstream through the alveolar membrane. Carbon dioxide diffuses out of the bloodstream through that same membrane. So we have a two-way flow going. The oxygen is coming in, carbon dioxide is going out. Oxygen diffuses in because the partial pressure of oxygen in the lungs, that is the total volume of oxygen in the lungs, is greater than the concentration of oxygen in the bloodstream. Let me put it another way. The partial pressure of the capillaries for oxygen is less than the partial pressure of the alveoli for oxygen. So you have an oxygen gradient going from higher to lower pressure from the alveoli into the capillary. Likewise, carbon dioxide, partial pressure of carbon dioxide in deoxygenated blood will be higher in the capillaries than it is in the lungs, in the alveoli, and therefore carbon dioxide will diffuse out. So we got this two-way flow going on. Important thing to know, and I'm not going to get too much into the chemistry of this, but carbon dioxide has a higher coefficient of diffusion than oxygen does. And what I mean by that is that carbon dioxide diffuses more easily than oxygen does. Therefore, damage to your lungs will lower your oxygen exchange more rapidly than your CO2 exchange. In other words, if my lungs are damaged, the amount of oxygen I'm going to take in is going to drop more significantly than the amount of carbon dioxide I'm removing is going to go out. It's easier to get carbon dioxide out than it is to get oxygen in. Now, in a healthy adult, respiratory membrane has a total surface area of about 70 square meters. Take that all apart. Differences in surface area are going to impact the gas exchange, but not at first. You have way more lung capacity than you need. Assuming you're not pushing yourself, assuming you're at a state of rest, your lungs are taking in more air than you require. In fact, if you weren't pushing yourself at all, if you were just going along, you would not have serious impairment of gas exchange unless your capacity to take in oxygen was reduced to between 1/3 and 1/4 of its normal value. In other words, you can lose between 66% and 75% of your lung capacity before you're no longer able to effectively take in the amount of oxygen you need. That said, that's with doing no exertion at all. Even small amounts of exertion, you're going to start to feel the pinch if your surface area for gas exchange has been reduced in any way. What's going to reduce that surface area? A couple of things. Cancer will obviously reduce that surface area for gas exchange. Emphysema will reduce that surface area. Surgical removal of lung tissue for any reason will reduce that surface area. And if you can't inflate the lungs as much, if your compliance is down because of pulmonary edema, bronchospasms from an asthma attack, or whatever else, that reduces the available surface area for gas exchange. Likewise, the diffusion of air in and out of the lungs is more efficient with a thinner membrane. We want that membrane to be really thin. The alveolar wall is a simple squamous epithelium because that's the thinnest possible membrane. Makes it easier for the gases to go in and out. Now, if we thicken that membrane, diffusion is going to slow down. It's not going to be quite as efficient. And that means that anything that causes inflammation or thickening of that membrane is going to be bad for our capacities here. What can make that happen? Thickening of the alveolar membrane can result from tuberculosis, the lung disorder. It can result from pneumonia. That's the big danger of pneumonia, that it causes thickening of the alveolar membrane and reduces your capacity for gas exchange. It can be caused by silicosis, which is the inhalation of fine particles building up in the lungs. That can happen as a result of inhaling industrial pollutants, the most famous example being a condition that used to afflict coal miners and steel workers a lot called black lung disease before we had special breathing apparatus to control for that. Garment workers actually got hit with an equivalent called brown lung disease. And if you're a smoker, well, you're reducing your vital capacity a bit by thickening your respiratory membrane with continuous irritation. If that membrane thickens by even double its normal thickness, you're going to find that your capacity for gas exchange drops drastically. And therefore, you can't afford to have less membrane in those situations. You can see where the combination of a thickening of the respiratory membrane and the loss of lung tissue with emphysema will eventually lead to a lethal scenario. All right, it's all sounding good? Okay, folks, we've talked about some basic mechanisms here for how we get the air in and out. We are not quite done with the respiratory system yet. To finish this out, I would like to talk to you all briefly about the regulation of ventilation, and I would like to talk to you about some respiratory disorders and some things that can happen with aging. But we've gone for about as long as I go for a normal lecture, so I think we're going to cut this short at this point. Your next lesson might be a little bit shorter to tie off the respiratory system, and then we'll deal with how we regulate breathing, how things like exercise and aging change it, and we'll talk about a few select respiratory disorders. I'll see you all soon. Have a good day.